Knocking us. Knock. Okay, good afternoon, everyone. My name is Ariel, if you haven't met me, one of the PGY1 residents. Today I'm going to talk to you about the treatment for spinal muscular atrophy, and I'm going to abbreviate it SMA throughout the presentation. So I currently have no disclosures for you guys about any potential financial or personal relationships with any of the companies or competitors in this presentation. So today we're going to describe spinal muscular atrophy, including its prevalence and genetic components. Then we're going to be able to identify the different types of SMA and which symptoms go with which type. We're also going to compare and contrast the current disease-modifying therapies for SMA and talk about the clinical trials that led to those drugs' approval. And by the end of the presentation, we should be able to design a treatment regimen for SMA based on patient-specific factors. So here's today's outline. First, we're going to talk about SMA in general, what it is, the different types, the genetic components. Then we're going to talk about Nusinersen, which is Spinraza, and I will refer to it as Spinraza throughout the presentation. Then we'll talk about omnisemnogene abiparvovec, which is Zolgensma, and then we will compare the two therapies. So SMA is a genetic neuromuscular disorder. It is characterized by muscle weakness and skeletal muscle weakness as well. The incidence of this disorder is 1 in 11,000 live births. In 2018, there were 80,000 births in the state of Tennessee. So with this incidence rate, there would be about 7 babies that would be at risk for having SMA in the course of this past 2018. Screening for SMA is now included in most newborn screenings. It is recommended. Some states haven't put it into law yet. Tennessee does recommend it, but it is not required. So SMA is an autosomal recessive genetic disorder. It is caused by deletions and loss of function mutations in the genes encoding for survival motor neuron 1, which would be SMN1, and this results in inefficient expression of survival motor neuron protein, which would be SMN protein. The prevalence of being a carrier for this disorder is 1 in 54. And without a proper level of SMN protein, your motor neurons in the spinal cord are deficient and thus prevent the body's muscles from receiving signals from the brain. This can lead to progressive muscle weakness and atrophy, which is what you see in patients with this disorder. So with that being said, what is the % chance that a baby born to 2 parents who are both carriers of the disorder will have SMA? I heard B, and that is correct. So now we'll talk about the different types of SMA. The classification of SMA is based on the age of symptom onset and the most advanced motor milestone attained during the development of those patients. Patients with a higher SMN2 copy number and have a higher level of SMN protein and will have a less severe phenotype. There are types from 0 to 4, and as you can see on this diagram that I put on the right side of the screen, the more SMN2 backup genes that you have, the less severity, and I'll describe that in the next slide. So type 0 is for babies with a prenatal onset. These babies have decreased fetal movement, which looks like weakness and hypotonia. This is the poorest prognosis, and most babies do not survive delivery. Type 1 is for infants between 0 to 6 months of age. This is usually when those symptoms will present. It's also called Wortnick-Hoffmann disease. These infants will have muscle weakness and difficulty breathing or swallowing. They are able to sit unassisted sometimes, and these babies will have symptom presentation. So they're not necessarily born with the muscle weakness and the trouble breathing. They should be fine for a couple of months, and then all of a sudden they have difficulty breathing or muscle weakness. This is the case for 60% of patients who are diagnosed with SMA. Type 2 usually occurs in patients who are 3 to 15 months. This is also called Debowitz disease and is more of an intermediate form of SMA. So these infants will have delayed motor milestones. They will also probably have had a prior ability to walk or stand, and then you kind of see this decline in their function. They will also have progressive scoliosis. Type 3 is also called Kullberg-Wellender's disease, and this would be juvenile SMA. So this type of SMA can occur in patients anywhere from 18 months to teenage years, 18 years old. These patients would have had the ability to walk, eat, stand, and then kind of suddenly start to lose that ability and end up wheelchair bound. This occurs in 30% of cases. And the last type, type 4, occurs in adulthood for the most part. It can present earlier, as early as 18 years of age, but usually this diagnosis is reserved for patients who are older in that 30 to 35-year-old gap. They have achieved major milestones and then start to have some mild motor impairment, and this occurs in less than 5% of patients who have SMA. So the later the presentation of the symptoms, the milder the progression of the disease state. So like I said, the different types of SMA depend on when those symptoms presented, as well as the age of the patient and the severity of the symptom presentation. If you have type 0 SMA, your life expectancy is usually less than 6 months, and like I said, they usually don't survive delivery. Type 1 patients usually do not survive past 2 years of age. Types 3 and 4 usually progress into adulthood, and type 2 is very variable. Some patients make it into young adulthood and some do not. So I do have a patient case that I've kind of sprinkled throughout this presentation. So XX is a 2-month-old female. She has poor head control and poor feeding and hypotonia. She doesn't have any signs of any type of systemic infection or disease, no fever, no rash, and her labs are within normal limits. Her newborn metabolic screen also showed no abnormalities. So labs were going to be drawn for her to explore other causes for her symptoms, and a genetics consult is ordered. After her genetics consult, the patient was discharged home to follow up outpatient. She had a hypotonia panel done, and that showed 2 copies of SMN2, as well as a homozygous deletion of the SMN1 gene. So based on that information, what type of SMA would you give XX? I see a 1, and 1 is correct. So current treatment for SMA includes supportive measures as well as these 2 disease-modifying therapies. Supportive measures would be ventilatory support. If patients aren't able to swallow or eat, they would have enteral feeds or any type of mechanical help that would help them to kind of get around with their muscle weakness, so like wheelchairs or any type of walking aids. Spinraza and Zolgensma are the only 2 medications that are indicated for SMA. Spinraza came out first and Zolgensma is newer, but Zolgensma does have laboratory requirements that I will discuss later in the presentation. So first we're going to talk about Spinraza. I'm going to go over its mechanism of action and how it's dosed, and then we'll talk about 2 clinical trials. So Spinraza is a survival motor neuron directed antisense oligonucleotide. I can never say that word. It is indicated for pediatrics and adults, and it works by increasing exon 7 inclusion in SMN2 messenger RNA, and that increases the production of full-length SMN protein. So SMN2 is the backup gene. When patients are deficient in SMN1, SMN2 is able to produce some SMN protein, but it doesn't produce enough for patients to be completely unsymptomatic. So the number of copies of SMN2 that you have usually relates to a less severe phenotype. So if you have 3 or more copies, you generally have a milder phenotype and a milder presentation of symptoms. So here's kind of a visual of what Spinraza is doing, kind of helping out that SMN2 gene to produce more proteins. So Spinraza is intrathecally administered. Patients must be loaded for 4 doses and then receive therapy every 4 months afterwards. The 4th and final loading dose is given 30 days after the 3rd loading dose, and patients must remain on this medication for the rest of their lives. Prior to administration of Spinraza, patients need to have baseline labs completed. So that it would include a platelet count, prothrombin, and urine testing for protein, because there are side effects of thrombocytopenia as well as some renal toxicity. And patients who are at an increased risk of coagulation abnormalities or some type of renal dysfunction, you would want to monitor those patients closer. So ENDEAR and CHERISH are the 2 clinical trials that brought Spinraza to market. There were 2 other more supportive trials that I'm not going to include in this presentation. So ENDEAR was the phase 3 trial that helped to bring Spinraza to market. This one was in infantile onset SMA. It was double-blind, randomized, and occurred from August 2014 to December 2016. Patients in this study had to be less than 7 months old to be included in the study, and with symptom onset no later than 6 months of life. The ENDEAR trial had 2 primary endpoints. The first one was motor milestone response, which was based on the results of the Hein Index, which is the Hammersmith Infant Neurological Examination. The second endpoint was event-free survival, which was defined as time to death or the use of permanent assisted ventilation. Permanent assisted ventilation included the use of a tracheostomy or other ventilatory support for more than or equal to 16 hours a day or more than 21 continuous days in the absence of an acute reversible event. Secondary endpoints included improvements in the CHOP and 10 scores and percentages of patients that did not pass away. Patients were given Spinraza on days 1, 15, 29, and 64. Patients were assessed 1 day after their doses, starting with the day 15 dose, and then about every 4 months after their 4th dose. Motor milestone response was assessed once patients had received all 4 doses, starting on the day of that 4th dose, which would be day 64. The Hammersmith Infant Neurological Examination is a 3-section, 37-item quantifiable assessment of overall neurologic function in infants. It has specific sections, and Section 2 is specifically for motor function, and that looks at the achievements of motor milestones. Scores in the Hind 2 range from 0 to 26. Higher scores indicate better motor function. So Hind 2 evaluates motor milestones in 8 categories: voluntary grasp, kicking, head control, rolling, sitting, crawling, standing, and walking. Patients who had been enrolled for at least 6 months assessed 7 of those categories, not including voluntary grasp was the one that was not included, before the procedure and on days 183, 302, and on day 394. They were considered to have had a motor milestone response if they had an increase in the score in at least one category and more categories with improvement than categories with worsening. Patients who passed away or withdrew from the study were considered to have had no response. So CHOP-INTEND stands for the Children's Hospital of Philadelphia's Infant Test of Neuromuscular Disorder and evaluates motor skills for patients with SMA. It has 16 categories that grade muscle function and motor abilities. Patients are graded on their motor ability for right and left extremities, as well as hand grip, shoulder, hip, neck, and elbow flexion, head control, and ability to roll. Each skill is given a score 0 to 4 for describing what you would consider like optimal ability. Total scores can be from 0 to 64. The maintenance of scores of more than 40 were considered clinically meaningful. The difference between CHOP-INTEND and the Hind score is that CHOP-INTEND is more extensive. They're not different in the aspects of which one is kind of better at assessing. They both assess motor function. This one is just more extensive. Hind was also done or created in London, so one's American and one's British. So here on this slide, I've put up the results of the ENDEAR trial. Serious adverse events were defined as symptoms that cause severe discomfort, incapacitation, or substantial effect on daily life. Serious side effects were considered those that resulted in death or an increased risk of death, hospitalization or prolonged hospitalization, persistent or substantial disability or incapacity, or some type of birth defect or anomaly in that sense. The most common side effects were pyrexia, respiratory infection, distress or failure, and constipation. And you can see here that patients in the control group had an 80% risk of adverse event compared to 56% in the Spinraza group. In the final analysis, 51% of the infants in the Spinraza group had a motor milestone response. No infants in the control group had a motor milestone response, and this is highlighted in the blue box on your screen. In the Spinraza group, 22% of infants achieved full head control, 10% were able to roll over, and 8% were able to sit independently. 1% were able to stand. In the control group, no infants achieved these milestones. 71% of patients in the Spinraza group had improvements in CHOP-INTEND scores, defined as an at least 4-point increase from baseline compared to the control group, where only 3% of patients saw improvement. This is highlighted by the bright turquoise box on the screen. 84% of patients in the Spinraza group did not pass away compared to 61% in the control group. The likelihood of event-free survival was significantly higher in the Spinraza group than in the control group, most notably among infants who had a disease duration at screening that was no longer than the median duration, which would be 13.1 weeks. The ENDEAR trial concluded that patients who received treatment with Spinraza had an increased likelihood of improved motor function and prolonged life. Risk of death or permanent ventilatory assistance, as previously defined, were 47% lower in the Spinraza group. The trial was actually terminated early based on the interim analysis results and out of ethical consideration for patients in the control group. Because the trial ended early, maximum response is still not clear. Not all patients continued for the entire 13 months of the trial, and so many data points, included data from day 183, 302, and 394 were used in the final analysis, as opposed to just using all the data from 394. And this can result in some variability. The CHERISH trial is another phase 3 study, but this was in later onset SMA patients, whereas the ENDEAR trial was in infantile onset SMA. This was another double-blind randomized study that happened in November 2014 to February 2017. To be included in this study, patients had to be in between ages 2 and 12 with no history of ability to walk unassisted, although they were allowed to be able to sit independently. Patients also had to have an HFMSE score of 10 to 54, which I'll explain what that is later. The primary endpoint for CHERISH was change in baseline HFMSE scores. The secondary endpoints included the ability to stand or walk alone, as well as changes in motor milestones. The screening period for this trial was 4 weeks, and patients were separated into 2 different groups, so less than 6 years of age or greater than or equal to 6 years of age, and then randomized to 2 treatments in a 2-to-1 randomization. The treatments took place over months on days 1, 29, 85, and 274. Scores were assessed at month 3, 6, 9, 12, and 15. The HFMSE score is the Hammersmith Functional Motor Scale Expanded. So this looks at SMA in patients with type 2 or type 3. It has 33 items, and those items are each graded from 0 to 2, with 2 being a full response, and each of those items is a measure of motor ability. Changes in scores of at least 3 were considered clinically meaningful in this study. And to be included in this study, patients had to have had a baseline of 10 to 54. So a total of 179 children were screened, and 126 were enrolled in the trial. They were randomly assigned to a group and underwent the assigned procedure. There were 84 children in the Spinraza group and 42 in the control. In the final analysis, there were 66 patients in the Spinraza group and 34 patients in the control group that had completed the 15-month assessment. As seen in the purple box at the top, the patients in the Spinraza group had an average positive 4-point change in their baseline scores. A higher percentage of children in the Spinraza group than in the control group had an increase from baseline to month 15 in their scores of at least 3 points, and that is in the blue box. The percentage of children who achieved at least 1 new motor milestone did not differ significantly from the control group to the Spinraza group, as that is in the green box. So these 2 graphs show the change in baseline scores. Each little blue circle is a patient in the Spinraza group. Each little gray triangle is a patient in the control group. And this shows changes in scores based on their age at screening or symptom onset in the purple square, or based on disease duration, which would be in that lime green square. Disease duration is defined as the patient's screening age minus the age of symptom onset. So you can see a positive correlation between the younger the patient is and their change in their score, as well as a possible benefit with early diagnosis. The dotted lines indicate a 3-point change in the scores, which is considered to be clinically meaningful. So the CHERISH trial concluded that there were significant improvements in baseline score changes for patients, which meant meaningful changes in their clinical course. There were no new safety concerns identified. The most common side effects patients had were headache, back pain, which would be consistent with the intrathecal administration of the medication, respiratory infections, pyrexia, and vomiting. So I put a chart in to kind of compare the two studies because they did use different measures of mobile ability. So the ENDEAR trial, like we said, is for patients who were less than 6 months of age, while the CHERISH was for older patients. ENDEAR used the Hines score and the CHOP INTEND, while CHERISH used the HFMSE score, and that score is specifically for patients who are older. They were both phase 3 double-blinded randomized controlled studies, and they both looked at motor response. So back to our patient case. So she previously was not a candidate for Zolgensma and was thus started on Spinraza so as not to delay any type of therapy and to protect her motor neuron function. Prior to initiation of Spinraza, the patient had failed swallow studies of all consistencies and thus was given an NG tube for nutrition. She has received 3 doses of Spinraza and her family is now ready to reconsider possible administration of Zolgensma. So now we're going to talk about Zolgensma. I'm going to go over the mechanism of action and dosing, and then there are 3 clinical trials that are relevant. So this gene therapy uses adeno-associated virus 9, which I'll have abbreviated as AAV9 throughout the presentation, as a vector to deliver the gene therapy. It received approval on May 24th of this year for children less than 2 years of age with SMA type 1. And this therapy delivers a copy of the gene encoding the SMN protein into the motor neuron of the patients, and then those motor neurons can make the SMN protein that the patients are deficient in. So Zolgensma is a 1-hour IV infusion and is dosed in vector genomes per kilogram of body weight. Prior to treatment, patients must start a corticosteroid equal to 1 milligram per kilogram per day of prednisolone. This prednisolone or prednisolone equivalent is continued for 30 days and then slowly tapered off over 28 days. Before receiving Zolgensma, patients are required to have a AAV9 antibody test done and baseline labs performed. So for our patient, she did not pass the AAV9 antibody test, but her baseline labs were normal. They're also required to start the daily corticosteroid at least 1 day prior, as we have already mentioned. Zolgensma can cause increases in liver function enzymes, prothrombin time, platelets, and troponin, and that is why we have to establish a baseline. So patients who have those elevations stay on the prednisolone until they are back to normal. So AAV9 antibody testing determines how many antibodies to the virus currently exist in the body. If the ratio is too high, the therapy could theoretically be ineffective or cause safety concerns because the body is going to mount an immune response. The desired ratio is less than or equal to 1 to 50. The safety and efficacy of therapy with titers that are greater than 1 to 50 have not been evaluated. AAV9 antibodies increase with age and it is believed they can be passed through the breast milk. So for our patient, she was receiving breast milk. Her mother did get tested and she did have higher titers, so the breast milk was stopped. And I thought this was interesting to point out because we usually, promote breast milk. Breast is best for our patients, but in a patient who is supposed to be getting this gene therapy, they would be switched to formula so that their levels could either decrease or remain low. So after you receive the one-time infusion, your laboratory values do have to be monitored. Liver function and platelet count have to be monitored weekly and for 1 month, and then every other week for 2 months after that until they have normalized. Troponin is measured weekly for a month and then monthly until normal. So the START trial was a phase 1 trial. This was an open-label, non-randomized trial that took place from May 2014 to December 2017. The primary outcome of this trial was safety. The secondary outcomes included death or time to permanent ventilatory assistance. This trial also looked at motor milestone achievements, especially sitting unassisted, and looked at changes in CHOP and 10 scores. To be included in this trial, patients had to be less than or equal to 6 months of age. The onset of disease had to be either at birth or up to 6 months of age, and they had to have significant hypotonia. Patients were excluded if they had viral infections or other serious types of infections, if they required ventilatory support at baseline or had titers that were greater than 1 to 50, if they had any signs of aspiration, and if they had any base substitutions in SMN2, because that would give them a milder phenotype, and so they wouldn't have very severe symptoms to track. So all patients had genetically confirmed diagnosis of SMA, or specifically SMA1. Cohort 1 had 3 patients with an average age of 6.3 months, and that was the low dose cohort. Cohort 2 had 12 patients with an average age of 3.4 months, and this was the high dose cohort. Short-term safety was evaluated over a 2-year period. Patients were tested at baseline and returned for follow-up visits on days 7, 14, 21, and 30, followed by a once-monthly checkup for 12 months after their dose, and then every 3 months for 2 years. Unscheduled visits were allowed as necessary. Then after the 2-year study period, patients were able to be monitored annually as per care, the standard of care for 15 years. "56 serious adverse events were seen in 13 patients from both cohorts. 2 were considered treatment-related with significant increases in LFTs up to 35 times the upper limit of normal. These required the administration of prednisolone. Of the 24 non-serious adverse events seen, 3 were considered treatment-related with asymptomatic increases in LFTs that were less than 10 times the upper limit of normal but did not require any prednisolone treatment. Other common adverse events included upper respiratory tract infections, GI disturbances, and pyrexia." So this figure shows the duration of patient survival free from needing any type of permanent ventilation with reference to the secondary outcomes. So each horizontal bar represents a patient in the cohort, and which cohort they belong to is on the left-hand side of the screen. The small black circles at the beginning of each colorful bar show when treatment was initiated. The stars at the end of the bars indicate patients who completed a 2-year safety follow-up. The vertical lines show control comparison. And for example, in the historical cohort, there were only 8% of patients who were symptom-free and event-free at 20 months of age. All patients reached at least 20 months of age without requiring any type of permanent ventilation. Patient 2 in cohort 1 required ventilation due to hypersecretion. When that hypersecretion got fixed, the patient no longer required ventilatory support, and that is what that little black donut shape is at the top. So these two charts show exploratory outcomes, specifically the motor milestones. This shows changes in the CHOP INTEND scores for each cohort. So the CHOP INTEND scores, again, they range from 0 to 64, with score maintenance above 40 considered clinically meaningful. The dashed line in between each patient-specific point indicates either a missed assessment or partial assessment due to fatigue or lack of cooperation for the patient. So each line correlates with the colorful lines that were on the last slide. All patients had increased scores from baseline in their CHOP INTEND scores. Patients in cohort 2 had mean increases of 9.8 points at 1 month and 15.4 points at 3 months. 11 of the 12 patients maintained scores of more than 40 points. At the study cutoff in August, cohort 1 had an average increase of 7.7 points from a mean baseline of 16.3 points. Cohort 2 had an average increase of 24.6 points from a mean baseline of 28.2 points. Eleven of the 12 patients in cohort 2 were able to sit unassisted for at least 5 seconds. 10 were able to sit unassisted for at least 10 seconds. And 9 were able to sit unassisted for at least 30 seconds. "11 achieved head control, 9 could roll over, and 11 patients were able to speak and swallow without assistance. All 15 patients surpassed the previously reported median age of survival of 10.5 months for patients with SMN1 with 2 copies of the SMN2 protein or gene. All patients surpassed benchmark of 20 months of age, and previously, like we said, only 8% of patients had survived without needing any type of permanent ventilation. Within the first month, cohort 2 had a mean increase in CHOP INTEND scores of 9.8 points compared to the historical cohort that had a decline in CHOP INTEND scores. In conclusion, the administration of this gene therapy improved survival, motor function, and CHOP INTEND scores to levels not previously seen in untreated SMN1 patients. The STRIVE trial is a phase 3 trial that is currently ongoing. It is listed as open label. It is a single group assignment and multi-center. This trial started in October 24th of 2017 and is estimated to end at some point this month. The primary outcomes of this trial included the achievement of developmental milestones of independent sitting at 18 months of age, as well as event-free survival as defined as the avoidance of death and/or permanent ventilation. Permanent ventilation, again, is the use of tracheostomy or the requirement of any other type of ventilatory support for greater than or equal to 16 hours per day for more than 14 consecutive days in the absence of some type of reversible illness. Secondary outcomes include the ability to thrive, which would be defined as patients not needing nutritional support through enteral feeds or a G-tube or a J-tube or any type of feeding tube. It also includes the ability to tolerate thin liquids as well as swallow appropriately. Patients were also assessed to see if they could maintain weight. Another secondary endpoint included the ability of the patient to remain without any type of ventilatory support. Patients were included if they had SMA type 1, and patients had to be less than 6 months of age at the time that they were given the infusion. There are 3 treatment periods or 3 periods in this study. There's a screening period where patients' eligibility was determined, a treatment period where they were given the pre-treatment of the prednisolone as well as the IV infusion, and then a follow-up period that went up to 18 months of age. So in 2018, interim data was presented. Out of 22 patients, 21 were alive and event-free. CHOP INTEND scores had increased by an average of 7 points, and there is an 11.8 increase after 3 months of receiving the gene therapy. With regards to their motor milestones, patients were able to sit without support for more than 30 seconds. There were 3 in September and 8 as of December, and both of those are of 2018. In 2019, more data was released. So out of 21 patients, 19 were alive without any type of permanent ventilation. 1 patient passed away due to disease progression. Another withdrew from the study. 13 patients reached age 14 months without any type of ventilation, and 10 could sit without support for greater than or equal to 30 seconds. Safety observations were comparable to those in the phase 1, the START trial, and adverse effects including elevated LFTs, platelet counts, and thrombocytopenia were transient and did not cause any long-term issues for the patients. The STRONG trial is another ongoing trial. This one is open label and non-randomized. It is a phase 1/phase 2 trial. So this trial took place in December, or started in December 14th of 2017, and is estimated to end in June of 2021. The primary outcomes of this study are safety, as well as accomplishing an optimal dose to administer intrathecally to patients. Milestones were also looked at, as well as changes in their HFMSE score. Secondary outcomes included the walking milestone, whereas the primary would include the standing milestone specifically, and any changes in ventilatory support. Patients were included in this study if they had at least 3 copies of the SMN2 gene, and this study in particular looked at patients who were older, so patients had to be at least 6 months of age, but up to about 5 years of age. And they also had to be able to sit up independently. There were 3 cohorts for this study, so 3 different doses were looked at. Cohort A would be the low dose, B would be more of an intermediate dose, Cohort C was their high dose. Information about Cohort C has not been released yet and how they're doing in the study. So on October 5th of 2019, the company that owns Zolgensma decided to announce some interim data from this study. In patients who were greater than or equal to 6 months of age but less than 2 years old, the primary efficacy endpoint would be the ability to stand without support for greater than or equal to 3 seconds. The secondary efficacy endpoint was their ability to walk independently for greater than or equal to 5 seconds. Since treatment, 18 motor milestones were achieved among the 16 patients who received dose A or dose B, including 2 patients who gained the ability to stand independently, one of whom went on to be able to walk independently. In patients greater than 2 years of age, greater than or equal to 2 years of age, and less than 5 years old, the primary efficacy endpoint would be the change in their HFMSE score from baseline. Secondary efficacy endpoint would be their ability to walk independently for greater than or equal to 5 steps. Patients showed a clinically meaningful improvement in motor function, having a mean 5.9 point increase from their baseline scores at their most recent visit. In the responder analysis, half of the patients had a greater than or equal to 3-point increase, which was observed starting at 1 month post-treatment. Since treatment, 4 motor milestones have been achieved among 12 patients in the dose B group, including 1 patient who gained the ability to walk. But, as I said, there has not been any information released about patients in cohort C, which would be the high dose. All the patients in the STRONG study experienced at least 1 treatment-emergent adverse effect, and 13 patients were reported to have an effect that was considered by the investigators to be related to treatment. Serious effects were reported in those patients. A total of 7 serious effects were reported in 4 patients, and those included influenza, pneumonia, RSV virus infections, and elevated LFTs. There have been no discontinuations due to any of those effects and no deaths. So to compare the 3 studies, the START study and the STRIVE study were for patients who were less than 6 months of age, and they both used the CHOP INTEND to assess their patients. START was phase 1, STRIVE was phase 3, and they were both open label. The STRONG trial is for older patients who are aged 2 to 12 years of age and used a different mobility scoring tool, but that is appropriate for their age range. That was a phase 1 to 2 study and was also open label and also looked at intrathecal administration of the drug, whereas the first 2 studies looked at IV administration. So going back to our patient case. So XX was previously not a candidate for Zolgensma due to her AAV9 antibodies that were too high. So she was started on Spinraza, so we did not delay her therapy, and we wanted to protect her motor neurons. At that point, she was reassessed after receiving 3 doses of Spinraza, and her AAV9 titers were collected. So what does her AAV9 antibody titer need to be to qualify to get Zolgensma? D. Her titer was 1 to 50. So what labs does she need to get done in addition to her titer? That would be D, all of the above. What medication should she start in order to receive Zolgensma? A would be the correct answer. She has to have 1 mg per kg per day of prednisolone at least 1 day prior to initiation of this therapy. So this is an actual patient. Her real name is Delaney. She's real cute. She did receive Zolgensma on 11/8, so like last week. She did get her prednisolone, and so far, last I checked, she's doing okay. So in conclusion, I just wanted to kind of look at the 2 drugs and compare them really quickly. So Spinraza is administered intrathecally every 4 months, and you do have to be loaded, but this medication is indicated for all ages. Zolgensma is a one-time IV administration. Patients have to be less than 2 months of age, and they do have to have AAV9 titers that are less than or equal to 1 to 50. There is a significant cost difference per injection. So Zolgensma is $2.1 million, or estimated to be about that much, whereas Spinraza is $125,000 per injection. So in the first year of using Spinraza, you would spend probably about $750,000, and then it would be around $300,000 each year after that, because you wouldn't have to pay for the load. But if you think about it, you do the one-time $2.1 million injection, and in about 3 years it's paid for itself. You also don't have to keep giving your child intrathecally administered medications, which require them to make clinic appointments every 4 months and possibly stay in the hospital if there's any type of complications. And of note, before these two drugs came on the market, there was no other therapy. So before there was any type of drug therapy, patients were kind of just going to the hospital when they started having complications based on their breathing or based on their nutrition. They'd have to stay in the hospital. Those hospital bills would add up, and then even if patients were not admitted to the hospital, they would have to have multiple clinic appointments. You have to also think about kind of quality of life costs here, parents missing work or not being able to work because they have to take care of their child, any nursing requirements, and those type of additional costs that we don't usually think about. So to summarize, SMA is a rare autosomal recessive genetic disorder. There are 5 types of it, and each type has a different degree of symptom severity as well as symptom onset. Spinraza is the intrathecally administered medication, which occurs every 4 months after receiving the first 4 initial loading doses. Zolgensma is a one-time IV infusion, and the choice of regimen depends on the patient's age, whether or not they have antibodies, and what their symptom presentation is like. And it also depends on what their insurance is going to be able to cover, if you think about that as well. And with that, I will take any questions.
For the prednisone, how long do they stay on that? Is it eventually, are they able to come off once their lab readers are normal?
So the question is, how long do patients stay on prednisone? So they start one day before, and then they stay on it for 30 days. And then after 30 days, if their lab values are normal, then they begin a 28-day taper. So they're on it for about 2 months if everything goes well. If their levels after that 30-day mark are still elevated, then they would continue the prednisone. I saw that you could increase the dose if their levels were like significantly elevated and you needed kind of an extra boost of prednisone. But they stay on it until they normalize, and then they'd start a 28-day taper at all times. It's always a 28-day taper off.